asked Dr. Case to come and speak with us. She's actually a pediatric doctor, but she's working in an adult rheumatology clinic. And that's a clinic that's linked between Boston Children's and Brigham Women's. And so basically what they do is they have a transition clinic that is specific for people who have rheumatic conditions that were diagnosed early on in life. So she has a really unique perspective, and she's going to talk about some of the medical differences and conditions and things like that. And we're just very excited to share the information. If you guys have any questions throughout the session, just chat me directly. Carrie Spishiker, just chat me directly, and I will ask those questions to Dr. Case at the end of the session. She has a young son, so we pre-recorded everything so that there wouldn't be any interruptions, but at the end of the session, she's going to come in and answer some of our questions. So without further ado, I'm just going to play this recording that we have from her, and you guys can send me questions, and we will see you guys tomorrow as well.
Transitioning from pediatric to adult care in juvenile idiopathic arthritis. So to give you a sense of my background, so I don't have any disclosures, meaning I'm just paid by the hospital for my clinical work. I'm a med-peds rheumatology fellow, so that means that I've done, I'm board certified in adult medicine and in pediatric medicine, and I'm now in fellowship training for both pediatric and adult rheumatology. And so my training has been at Boston Children's Hospital and Brigham and Women's Hospital for adults. And I also come at this with some experience as a patient. So this is a picture of me when I was 17 in the process of going to college and transitioning. I had arthritis related to lupus when I was that age. And so every patient's story is different and everybody's experience is different. But I do bring a little bit, hopefully, of experience to this, not just as a provider, but also as a patient. So for the overview for the talk today, so we're going to talk a little bit about what does transitioning care mean, how do people get ready for that, how do they find the right adult care team. We're also going to go into a little bit about what is important to know about care for JIA in particular. So is it different from adult arthritis, and if so, how? And then how can we support our health? So what are some daily decisions that might actually make a difference for disease control? For example, are there certain exercises and foods? So when we think about going from the world of pediatrics to the world of adults, sometimes it can feel like we're so ready to make this move where we get to make all of our own decisions. We can stand on a large pyramid of animals out in the savannah and have fun. And the reality can sometimes feel a little bit different, right? It's about sort of the practical daily choices that we have to make to support ourselves and support our health. But ideally, the goal is that you're making this journey gradually, right? You're preparing for it when you're much younger. And so by the time you get to that point where you're making your own decisions and in control of your own health, that you're ready for it. And you're also not doing it alone, right? You have your team of people who are helping you do this. So the rest of this talk is going to be framed as the top 5 myths in JIA care transition. And I think anybody listening to this talk probably, hopefully knows that these are not true, but we'll just go through these as a way to think about some issues that can come up. So the myths are, first, that JIA is adult arthritis that starts earlier. Second, that transition just means seeing an adult rheumatologist. Third, that seeing an adult rheumatologist means leaving my pediatric doctors forever. Fourth, I have to know every detail about my care and manage everything independently. And fifth, my daily choices make no difference for my JIA. So tackling myth 1 here, that JIA is adult arthritis that starts earlier. So what is JIA? So juvenile idiopathic arthritis is inflammatory arthritis that starts at or before age 16 years old. And that's in comparison to rheumatoid arthritis, which is abbreviated RA, which is inflammatory arthritis after 16 years. Now, as you may imagine, there's not a magical different diagnosis that happens just because somebody is older or younger than 16. It's just sort of historically how things evolved when people were doing research and trying to figure out how arthritis, which is a big category, might be different for younger versus older people. And so for JIA, the incidence it varies a lot depending on country, but it's about 1.6 to 23 cases per 100,000 children globally. And part of this process we think might be antibodies, at least for some patients. And when we think about antibodies, there are several that are listed here. So one is called anti-nuclear antibody, or ANA. That can sometimes be seen in JIA. It's associated with having a higher risk of uveitis, which is inflammation in the front part of the eye. Otherwise, there's also what we think of as seropositive or seronegative. So seropositive means that there's either a rheumatoid factor, which is abbreviated RF, or cyclic citrullonated peptide, which is abbreviated CCP. And that's actually the case for most adults who have rheumatoid arthritis. About 50 to 80% of them have one or more of those autoantibodies. And that's in contrast to JIA, where really only 10 to 20% of folks have one of those antibodies. And then in JIA, the rest are seronegative, so about 80 to 90%. When we think about the joints that are involved in JIA, so as you know, it can happen anywhere, but in kids, sometimes it can also affect the jaw or the temporomandibular joint, and that's much more rare than in rheumatoid or adult arthritis. And then sometimes there's chronic anterior uveitis, so inflammation in the front part of the eye. That can happen in about 4 to 14% of patients with JIA. And then finally, there are some autoimmune conditions that are more common in patients with JIA, so things like celiac disease and autoimmune thyroiditis. But when we take a step back and think about how did these distinctions get set up? So the purple boxes are childhood onset arthritis, and the blue boxes are adult onset arthritis. And you don't need to get bogged down in the details, but this is just to see that there are a ton of different types even within JIA, right? So there's things like systemic JIA, rheumatoid factor positive or negative polyarthritis, psoriatic JIA, undifferentiated arthritis. And then on the adult side, there's, again, a lot of different buckets that they can fall into. And so the question is, how do these relate to each other? And also, why are there so many names, right? So there are many different pathways in the body that can lead to the same result that we're able to see and experience, which is arthritis. And we try to find differences within arthritis and including JIA that can offer clues about how to treat it, right? So if there's all these pathways that can lead to the same result, how do we figure out which one of them is causing the problem so that we can target that and not cause side effects by targeting too many of the pathways? So for an example, if you have a study of a new medicine and you include people with what we think is JIA, we think it's the same disease, but they actually have two different diseases, we might think that the drug doesn't work well for most people, but in fact, it could work great for a subset and not work well for another group. And so we just have to try to think about how to distinguish different pathways within arthritis. So these are some of the biology basics of arthritis. This is from a paper by Dr. Nikrovich et al. And the good news is science has come a long way, right? So we understand a lot more about how biology is working with arthritis and some of the differences within arthritis. So these are just 3 examples. So one is at the top here, you can see synovitis on the left. Synovitis is inflammation of the lining of the joint, versus enthesitis over on the right side of the screen. So that's inflammation in the places where the ligaments and tendons around the joint are inserting to the bone to hold everything together. And so, for example, synovitis is a key feature of rheumatoid arthritis. Enthesitis is a key feature of spondyloarthritis. And might there be some differences in how the biology of that works that we might need to treat differently with different medicines? A second feature here is, as we talked on a previous slide, whether or not there are autoantibodies. So in seropositive rheumatoid arthritis, things like CCP and rheumatoid factor versus seronegative arthritis, where we're not able, at least not yet, to detect specific autoantibodies. And so could there be another type of cell in the immune system that's causing that process, for example, T cells? And then a third distinction here is autoimmune versus autoinflammatory. So I think inflammation gets gets sort of a bad rap. Actually can be a good thing, right? So it's part of healing, it's part of fighting off infections. And similarly with the autoimmune piece, right? Our bodies are supposed to make antibodies to fight off infections and that, but both pieces of that system can get a little bit confused. And so in rheumatoid arthritis, we think a lot of that is driven by more the autoimmune side with autoantibodies, whereas things like systemic onset JAA or adult onset Still's disease, those are really more autoinflammatory diseases. So this is, again, the same paper by Dr. Nigovich et al. Is trying to think about creating a new model that goes across ages. So you can see here, there's these different colored circles that have a lot of overlap. So it's not a perfect independent system of totally separate types of arthritis. But in general, we think there might be a category of seropositive arthritis related to autoantibodies, seronegative arthritis that's independent from that. And within that, you see this yellow circle that's called early onset. And that would include a lot of folks who have JIA. So the idea that it's arthritis that's early onset. There's also a pink circle for systemic JIA, also adult onset Still's disease, and then this purple circle of spondyloarthritis. And why does this matter, right? Why do we need to redefine these categories? Well, first, it can help us find common pathways to target for treatment. Second, it can help us find parallels in research, right? So there's a ton more adults who have arthritis than kids. And so it's easier to recruit adult patients for studies. And if we can start by using those higher numbers to recruit patients for studies for medicines, it can ideally help us get more options on the pediatric side. And again, this matters because the Federal Drug Administration, or FDA, it regulates drugs and approves them based on a specific indication, so a specific diagnosis. And so just because a drug is approved for rheumatoid arthritis, it doesn't mean that it's going to be approved for patients with JIA. So as a caveat of that, or a consequence, you might note in your chart, if you do transition to an adult rheumatologist, that suddenly it says you have a different type of arthritis. And it's not because they're confused or because you suddenly have something else. It might just be their way of trying to explain to the insurance companies why they're choosing a specific medication to treat you. All right, so that is myth one. So that as we know, there are some differences in pediatric and adult arthritis, but perhaps not as many as we thought in the past. So moving on to myth two here. So this is that transition just means seeing an adult rheumatologist. So I think everyone who's attending this talk knows that it's not that simple, right? So this is a general picture of what a journey to healthcare transition might look like. So you start the journey, you begin planning things, you keep building your transition plan, you prepare to move to an adult model of care, schedule adult visits, actually attend the visit, and then eventually transition. And there's a ton of factors that go in that are not pictured here to sort of give you concrete skills that you need to take over managing your own health. So what are some concrete checkpoints about where do we start in this process? So there are sort of national guidelines, not just for JAA, but for folks with any different chronic condition, about how do we gradually gain the skills to become independent managers of our health. So oftentimes around age 12, we'll encourage patients to ask your provider questions, to rethink what is your understanding of the chronic condition like JAA, the medications that you need to take for that. And then asking about a transition guide or policy that the clinic might have can just be a helpful blueprint to keep in mind for the future. Oftentimes around age 14, this is when providers often ask to see patients alone for a certain period at each visit, not because anything secretive goes on then, but just because we recognize that it's a process to learn how to communicate with your medical team, to gain the confidence in doing that, forming questions, asking them, having discussions. And so it's just good practice, just like any other skill. There's also what are called readiness assessments. So these are sort of tests that you can take to try to say, okay, these are the 10 different skills that we think are probably really helpful in managing a chronic condition. And which one of those, where can we sort of pinpoint where we might need some help? You can also practice making appointments, organizing your medications, making emergency plans about if a symptom pops up, what to do about it. And then when people turn age 18, legally you're an adult. And so that means that your health information is private, that you're in charge of it. And if you want to share it with somebody like a family member, you have to fill out a consent form to do that. And then oftentimes around age 18 would be a good time to think about when you might need to move to adult care. So there's also, it's not so much on the patient side, but on the provider side, there's what we think of as 6 core elements of transition. So these are put together by a wonderful organization called Got Transition. And it's again focused on adolescents, young adults who have any type of chronic condition and trying to think through that process, the gradual transition to adult care. And the reason I put this here is I think it's helpful to know on the doctor side, like what are we seeing, what are we thinking about as we're working through this journey together. So these are the 6 bullet points, and I'll just briefly point out a couple things that might come up in that point in your journey with your medical team. So the first point is having a transition guide of policy. So this is something that ideally the clinic would have. And you could ask your team for a copy to review together. So for example, at what age do most patients transition? Is there an age cutoff? The tracking and monitoring, obviously you don't have to worry about, but that's something that we're trying to do on the provider side. And then for transition readiness, so this gets to the readiness assessments that we talked about, oftentimes helpful to take somewhere in the mid-teenage years. And then working concretely on building skills with your family and your medical team, making appointments, ordering medicines, talking with providers. Then when it comes closer to the time where we're around age 18, thinking about what we would need to do to plan that transition. So who is on your medical team? So primary care, rheumatology, sometimes people have ophthalmologists, all other sorts of doctors and providers. And so just write out who those people are and who you might need to see on the adult side. And then identify adult providers. So you can certainly ask your pediatric providers, you can check with your insurance system. If you're going to be moving to a new health system, that's a different medical record, then you may need to call them to register. And then there's the actual, you fill out consent forms. So for example, sharing medical information with your family, especially if you're over age 18. And then request a copy of the medical records. So this is, I wish it were simpler to tell new medical system what had happened with your previous doctors, but oftentimes it gets tricky to fax the forms and things can get lost. So oftentimes it's helpful to have your own copy. And that's not because you need to read through it or know every detail, but just it's sort of empowering to have that information yourself so that if a provider needs it down the line, that we can help get that to them. And then tell your pediatric rheumatologist that this is something that you need their help with, and they're happy to be a part of that process. Then there's the actual transfer of care. So you go see a new provider. It's helpful to ask about how things work. So for example, what to do in an emergency, how to get in touch. You want to think about new prescriptions. Separate from that, there's also some people need infusions. So getting medications through an IV, and just like your transitioning doctors, you may need to transition that to an adult hospital. Getting referrals for any other team members that you might need to see. And then finally, ongoing care. So continue building your adult medical team, update your pediatric rheumatologist to get feedback on the process, and continue building self-management skills. So this is, again, just a broad overview, what we think about from the provider side and how that might translate to what you're experiencing as a patient. All right, so myth 3. When I see an adult provider, I am leaving my pediatric rheumatologist forever. So I think this is understandably something that we oftentimes hear from our patients that they worry about in transition, that they have a long-term relationship with this other provider that they've really come to trust, that they understand how to work with them, and it can feel scary to go to the adult world from that. So I'll just say, keep your pediatric team updated, right? They really care about you. They want to help. They want you to succeed. And we also need feedback to know how to make this process better for other patients. So some examples for this, so sending a message in your online health portal of questions, updates, or feedback. Some people find it helpful to actually set up an appointment to go back to see their pediatric rheumatologist, even after they see the adult one for the first time, just to check in, make sure that everything is going smooth and that it's a good fit. And then there are also community events. So things like the Arthritis Foundation's Jingle Bell Run, which I know the Boston Children's folks go to every year and can be a nice place to reconnect. And then, along those lines, I think the fear about moving away from pediatric care gets to what are some of the differences between pediatric and adult care. So these are pictures of the lobbies of two of the hospitals that I work at. So on the left here, we see the Boston Children's Hospital, and on the right, we have the Brigham and Women's. And they're both wonderful, beautiful lobbies, but there are some differences, right? So on the left, we see oftentimes there's friendly greeters, there's a musical staircase to go up. At the top of it, there's Seacrest Studios, there's an interactive media wall. And then on the adult side, there's a lot of gray and tan, nice clean lines, very, black and white photos and calming artwork. And it's just different, right? And so we actually did a focus group with some patients from our clinic who had childhood onset lupus, thinking about transition. And this is a quote that somebody shared with us. So they said, I know it doesn't seem like a big deal, but the pediatric hospital has pretty murals and staircases that you can run up and it makes noise. That makes me really happy. Then you go to the adult hospital and it's like gray and tan. Every waiting room looks the same. That has been really tough for me because it's like your environment affects your mood. So this is not to say that you won't enjoy the way that the adult hospitals look, but it's just to say there are differences, right? And we all recognize those differences. And so just check in with yourself and, acknowledge that it's going to be a little bit of a different type of care when you go to the adult side. But there are some really good parts of that too. So here's some of the other differences that might come up. These are summarized from a lot of the materials on the Arthritis Foundation site and Got Transition. So we have listed on the left side here, pediatric care versus adult care on the right. So oftentimes the pediatric visits are a bit longer. That's designed on purpose because oftentimes there's whole families and a lot of discussion with family members about how to manage things. And on the adult side, it tends to just be the patient and the provider, although certainly you can do whatever works best for your family. And so because of that, on the adult side, there are shorter visits. On the pediatric side, sometimes specialists like rheumatologists can provide a little bit of primary care. And on the adult side, it does depend on the provider, but oftentimes the specialist will work closely with primary care, but they don't always provide it. So an example might be, if you got a fever, and you're seeing your pediatric rheumatologist, you might call, check in, say, do I need to hold my medications? What tests do I need to do? And on the adult side, you would still call and check in about those medications, but they might need the help of your primary care doctor to think about what other testing you might need to look for the cause of the fever. Another difference here, so on the pediatric side, the family or the caregivers are often helping with things like appointments and medications, whereas on the adult side, the patient is responsible for those things. On the pediatric side, there's actually a smaller number of providers. So thankfully, there are not as many kids with arthritis as there are adults. And so that means that we don't have as many pediatric rheumatologists in comparison to adult rheumatologists. And so the good news with transition is that there might be a provider that's actually really close by to you. Oftentimes the pediatric rheumatologists are centered in bigger cities and children's hospitals, and adult providers might just be down the street from you. And then sometimes on the adult side, they also have a policy about no-shows. So it's just, again, something good to note. And when you go see your adult doctor for the first time, to talk about what their policies are at their clinic. So what are some tips for finding a friendly adult rheumatologist? So a first step would be thinking about where your insurance might cover. So sometimes people have been on a parent's plan, and that might change if they're going to do a different job or college after they graduate high school. And within any insurance plan, there might be providers that are either in network or out of network. And the out of network providers typically have a higher copay. And then good to plan in advance. So some new practices or some practices have wait lists for new patients that can be quite long. So something as long as 3 months. So you ideally want to get an appointment well in advance of when you think you might need it. And then ask your pediatric rheumatologist. It's a small community, and oftentimes we can help identify providers wherever you're going. As doctors, we do training in a lot of different parts of the country, and so we have tend to have good connections. And then if that's not helpful, oftentimes hospitals on their website will have brief biographies or descriptions for research interests of the different doctors that you might be able to see. An example is you could look for someone with med peds training like I have, so that you know that they have experience also with working in kids. And then maybe have a research interest in JAA. And then the last thing to know is if it's not the right fit, it's okay to find another doctor. So what matters most is that you find somebody that you trust, and the doctors will understand. We understand that we're not going to be the best fit for everybody under the sun, because sometimes people want different things from their providers. So, feel free always, if it's not the right fit, to go back to your pediatric rheumatologist or ask someone else and get a different referral. All right. So hopefully that's reassuring, against it's not so bad to go over to the adult side. Myth 4, I have to know every detail about my care and manage everything independently. So hopefully everyone knows that that is not the case, right? Doctors go to medical school for a reason, because it's complicated, and it is literally our job to explain things and help people understand. And so I would say know enough to be empowered, right? It's a good idea to know your medical conditions, to know your allergies, the medications that you take, and then what are called red flag symptoms. So that means symptoms that you don't want to just sit on, that you would actually have to act on, and who to ask for help if those show up. And then if you have a question, just ask us, right? Feel empowered to ask us. Just like anything we learn at a younger age, our understanding evolves over time. So this is an example. This is my son, and to him, basketball involves an orange stripy ball, a blue ball, and sometimes even a bathtub. And it will obviously change over time as he gets older and he's able to run around and dribble the ball and eventually shoot the ball in the hoop. But sometimes I think both as a patient and also as a provider, we forget that when we first learned about what our condition is or those medicines, it was years ago. And so our understanding may be really different now. And it's just good to check in about things. So feel free to ask questions. So an example of an issue that might come up during the time of transition and how you could troubleshoot it with your team. So, being empowered, but also asking for help. So the scenario is Leo has just arrived at college after moving in, and his hands are aching and stiff in the mornings. He is worried that the stress of the move is causing a flare. So what does he do? So this is great, right? He's recognizing some red flag symptoms, right? That he has stiffness in the morning, he's not feeling like himself, and he knows he needs to check in with his medical team. So he would know ahead of time, right, to contact his local support system. So who might that be? So family, friends, sometimes when we're just moving somewhere new and we're not quite established, for example, moving to a new college campus, it can be helpful to think about who you want to know that they can help you out if there's an emergency. So for example, an RA, a roommate, or somebody at student health. And then contacting your rheumatologist or your doctor. So depending on the urgency of it, sending a message in the online portal or having a backup plan like calling the hospital and asking them to be paged. And then also having a plan about where to go for care locally, right? So whether that's student health, urgent care, the emergency room, he would know his medical conditions and his medications, and those would be common questions to be asked. And then also having a transportation plan about how to get there. And then a pharmacy to send prescriptions to that he'd be able to get the medicines from. And so managing a chronic condition is a team effort, right? Everybody is different, but we can find support in a lot of places. So examples would be caregivers, family and friends, people in your everyday environment like teachers, classmates, and coworkers, your medical providers, so the providers themselves, social workers, physical therapists, the JA community at large, which is a wonderful, amazing group, and national organizations like the Arthritis Foundation. And your medical team is there for you, right? If you are feeling overwhelmed, please know that you can confide in us and that we're here to support you. And then I also think it's helpful to just say, try to keep some perspective, right? So empowering ourselves by learning about things through websites or social media is fantastic. But it's good to just always remember that everybody's different. Also, some websites are more trustworthy than others. So ones ending in .org, .edu, and .gov tend to be more well-researched and more reliable. Just as you are a unique person, your story with JAA will be unique. And treatments now are very different, thankfully, than the treatments we had even 10 or 15 years ago, right? So the reason I have a picture of a sparkly gold syringe here is not just to be flashy, but that actually was a treatment for arthritis not that long ago, that people would do injectable gold. And as you can imagine, it was not terribly effective, but that was sort of all we had. And now we have a whole wide range of different medicines. And so if you read a story about somebody who's now in their 30s or 40s who has JAA, their story is probably going to be quite different from yours, not just because you're two different people, but also because the field of medicine has come a long way since then. Adult arthritis is often different, right? And then I think there's also some oftentimes well-intentioned misinformation out there. So an example would be sometimes supplements can be helpful, but they're not regulated by the Federal Drug Administration or the FDA. And so in general, if anything is claiming to be a cure for something and it's really expensive, maybe just ask somebody else that you trust their opinion before buying into something. And certainly always feel free to ask your doctor. All right, so myth 5. My daily choices make no difference for my JAA. So this is a picture of the Ever Given as the JAA flare, and this poor little digger self-care trying to dig it out of the Suez Canal. And some days can feel like this, right? That it seems like no matter what we do, it's not going to make a difference with symptoms. But I will say self-care makes a difference. It's challenging to find the time and the resources to do that. And when providers ask you about it, it's not meant to be a report card, it's not meant to be graded, but it's just because we care about you as a whole person and we recognize that lifestyle can make a difference. So an example of this would be physical exercise, right? So there was a study that was published in 2017 that was a meta-analysis of exercise programs in JAA. So that means they took all the studies they could find that were published on exercise in JAA and tried to compare and see what was helpful. And the good news was they didn't see any worsening of joint pain or any worsening active arthritis. And in general, they saw across programs that seemed to improve people's strength and pain, so reducing pain and improving the quality of life. And again, because everyone's different, would just be good to keep in mind that you should check with your doctor if there's any sort of restrictions they'd recommend. But I think in general, if something is comfortable for you related to physical exercise, getting it regularly in your routine is a wonderful thing to do. Similarly, bone health. So peak bone mass happens in our mid-20s, and steroid use, which oftentimes we have to turn to, at least for short periods of time in JA, can weaken bones when it's used over time. Weight-bearing exercises may help. Again, ask your doctor to make sure that it's okay for you. And then also including vitamin D and calcium in your diet. So these are some examples of where you might be able to get that. And that can really be good. And I think this is probably good for people regardless of whether or not they have JAA, but again, because of the steroid use, it's even more important for folks with JAA. And then fueling our bodies. So there's not enough evidence to recommend any specific foods or diet in terms of symptoms. But I will point out one study. So this was in adult arthritis, so rheumatoid arthritis. And they took a bunch of patients and they asked them if they thought there were any foods that made their arthritis symptoms feel better or worse. And so it was true for about a quarter of patients. They thought that there was something that either helped them or hurt them. So the most common helpers were things like blueberries and spinach. So you can see over on the left side of this graph where there's higher gray bars, those are the foods that they felt like improved symptoms. And then the most common offenders were things like sodas, desserts, beer. And so you can see on the right side of the graph with the black bars, those are things that they felt like worsened symptoms. So the takeaways are listen to your body, right? For some people, food may make a difference. It's notable that for most people in the study, food didn't make a difference, but it could for you. And in general, trying to eat less healthy foods in moderation and trying to eat more healthy foods is probably good for all of us. And then lastly, I just wanted to mention the impact of resilience and optimism. So I think this is something that we don't always do a good job about talking about on the provider side, but can really make a difference. So resilience is the capacity to recover quickly from difficulties or toughness. And so an example of this is they did a recent study in the COVID pandemic in a town in Italy that they had really high rates of COVID. And they looked at patients with adult arthritis, so rheumatoid arthritis, and they measured their resilience. And they found that there was a much higher number of patients who had arthritis who had high resilience, so about 30%, versus only 16% of people who were controls, meaning they didn't have arthritis. And so there's a thought that having a chronic condition like rheumatoid arthritis in this study, or maybe like JAA, could prepare people better for other stressful events, right? They sort of know what to do when things aren't quite going right, and they have some skills to troubleshoot things. And then optimism, so related to this, is hopefulness or confidence about the future or the successful outcome of something. So an example of this is in the nurses' health study, women who had the lowest quartile for optimism had higher mortality than those who were in the highest quartile for optimism. So there is, I think, some biology to this, right? That having, when people are really sad or stressed about things, it has a negative impact on our body, which I think we can all feel, right? And so it's just good to, it's easy to say and hard to do, right? To increase your resilience and optimism. But I think focusing on things like gratitude and the positive aspects of having a chronic condition can be helpful. So this is a quote from that same study I mentioned earlier of patients who had childhood onset lupus in our clinic. So this is what one participant shared. I'm starting to think about my health when I was 18 as opposed to years later. Also, the job I have requires a lot of empathy. And I think I was an empathetic person before, but I think it's made me a lot better person. So there are these sort of optimistic takes on having a chronic condition that starts when you're a child. So in summary, hopefully we've gone through these 5 myths. So the first one, JA is adult arthritis that starts earlier. And hopefully you've seen that JA has some unique features, but it may have more overlap with adult arthritis than we used to think. Second, that transition just means seeing an adult rheumatologist. So transition is actually a process that we plan for and that may take years to complete. Third, seeing an adult rheumatologist means leaving my pediatric doctors for forever. So we recognize that there are differences in pediatric and adult care, but you can stay in touch and find a great adult doctor. Fourth, I have to know every detail about my care and manage everything independently. So know enough to be empowered and ask for help from your team. And then finally, my daily choices make no difference from a JAA, whereas daily choices that support physical and mental well-being can have a big impact on our health. These are just a couple resources. So the Arthritis Foundation has a great website on transitions for patients with JAA, and then Got Transition is another wonderful place to check in, and they have that transition readiness assessment that we talked about. So I'd love to open it up to questions, and thank you so much for having me. It means a lot to me to be a part of this wonderful conference, and I'm looking forward to your feedback. Thanks so much.